request all the faculties to collect the mementos from the outside. And now we are moving towards another short lecture. This is a peri-intubation care. For this session, we have Chairperson Professor Joydev Roy. Professor Roy is a principal in ICH Kolkata. He has been remained chairperson and president in various national bodies, and he has more than 50 publications in various journals. And the speaker of this session is Dr. Namit Gerard. And Dr. Roy is introduced him. Okay.
Next session is peri-intubation care. I think there is no need for the introduction of Namit Jain because he is the secretary of the IIP Intensive Care Chapter. He is the National Secretary of the IIP Intensive Care Chapter. And also he is the senior pediatrician in charge in PICU of Indraprastha Apollo Hospital of New Delhi. He is fellow of the Pediatric Critical Care, the Hospital for Sick Children, Toronto, and Sydney Children Hospital, Australia. Pediatric Emergency Medicine Training, Australian College of Emergency Medicine, and tenure of faculty of DNB Pediatric Critical Care, IIP College of Pediatric Care, and Sydney Children Hospital program. There's so many things is there, and I think when a child is intubated for any of the intensive ventilation of this thing, the care of the peri-intubation is one of the important thing, and we now will hear this thing no other than the Richen. Richen, please.
Thank you, sir, for the kind introduction. Good afternoon, everyone. First of all, I would like to thank the organizers for giving us this opportunity, and it's really a pleasure for me to be amongst you all here. So the topic for me for the next 20 odd minutes is to talk about peri-intubation care, and as you can think, it's a vast timeline as well. So peri-intubation starts before the intubation, and then after the intubation. So it's a wide subject to cover, and I'll try and restrict myself more towards the pre and just intubation part, and just touch on the post-intubation part of it. So we'll try and discuss about the intubation, the difficult airways, and just fleetingly refer to the care while the child is on ventilator. So intubation is a very significant event. And it is even more significant when it is done in an emergency situation, which is just about all the intubations that happen either in the intensive care unit or the emergency department. And one of the studies reviewing all the high-risk intubations or all intubations happening in the emergency department found just that the risk of having adverse events with intubation are much higher with emergency intubations, where you don't have nil by mouth, everything prepared, someone who has assessed the airway beforehand, which happens with the surgical intubations. So in this particular study, there were 20 emergency intubations which were associated with at least one tracheal intubation adverse event, 7 with severe adverse events, and at least there was one death amongst the 200 odd intubations. So if you think of those numbers and the number of intubations which happen in intensive care units across the country every day, that's a significant number of children who get or who are at risk of having an adverse effect because of intubation. So it becomes very vital that a pre-intubation assessment has to be done properly, because intubation will happen for so many reasons. The respiratory reasons, cardiac failures, the neuroprotection, muscular failure, airway protection, severe sepsis. This is just a very small of a very long exhaustive list of reasons where we would need intubation. But something which remains most important and most frequent is respiratory failure, where you have a significant number of children who get intubated because of respiratory issues. So a good assessment of the respiratory status, and when I say assessment, most of our assessment has to be clinical. So you have to have a high index of suspicion. Most of the times a good clinical examination will even zero down the point where exactly is the problem. Is it more of an airway disease or a lung parenchymal disease? Do you have stridor? Do you have more of V's? And ancillary laboratory tests have very limited value in making a decision of intubation. So assessment of oxygenation and ventilation is mainly clinical when you decide to intubate. You do not need gases or blood tests, or you do not need to wait for them to intubate a child. If you see a child who is sick and you get a gas which is perfectly normal, you will doubt the gas, not the child. So if you need to intubate, you need to intubate regardless of what the gases are. And oxygenation can very well be assessed by your pulse oximeter. In the ranges of around 92 to 97%, there's a very good linear correlation between the PaO2 and SpO2, and this gives you a very good idea of the oxygenation. Not so with the ventilation. And I'll show you with an example, and just to refresh your memories, this is the alveolar gas equation, where the alveolar oxygen depends on what is the inspired fraction of oxygen and how much of is the carbon dioxide in the alveoli. And let's apply this equation in two scenarios. So let's say there's a child who's breathing and his minute ventilation drops by 50%. So 50% drop of minute ventilation would mean half of the minute ventilation, and the carbon dioxide would just go up. So with a 50% drop in ventilation, there will be a 50% increase in carbon dioxide, which goes from 40 to 60. So not a significant change. CO2 has just gone from 40 to 60, and we'll do these calculations at both the levels. With the 40% for the 40 of CO2 and breathing room air, you see the alveolar oxygen is 74. And now you put the child on small amount of oxygen, only 30% oxygen, and you see the PaO2 is 138. So small amounts of oxygen can really alter the carbon dioxide assessment. So you can assess the oxygenation with the PaO2, but for carbon dioxide, most of the times clinical judgment is not enough, especially if the child is on oxygen. A corollary of that is more important, that if the child is maintaining saturations in room air, you can be absolutely sure that the ventilation is okay, or the CO2 is not a problem. So that's a corollary of that. Okay, so when you have decided to intubate the child, management of pediatric airway is very important. There are subtle differences compared to the adult airway. It has to be a stepwise approach. Airway positioning is very important. You can see a child with a large occiput, you need to put rolls under the shoulders, and you have been taught this over and over again, that you need to be aware, have all the equipment ready, suctioning, and have adjuncts ready with you. So to keep the airway open and to keep it clear, you would need suctioning. A child who's not able to maintain airways, you would need those airway adjuncts to help you with the airways. But what is equally important is to anticipate an anatomically difficult airway. So there can be so many reasons. Some children would obviously look syndromic to you, and you would just see the child and know that there is a chance of this child being a difficult intubation. Some of the times the condition of the child would be such that the child is not able to move the neck, or the child has had a cervical collar on. So there's so many reasons where you could think, or you would know beforehand, that this is going to be a difficult intubation or an anatomically difficult intubation. And people have classified these anatomical difficulties depending on the amount of mouth opening that is possible, the Malampatti classification, or what amount of vocal cords can you see when you put the laryngoscope in, which is the Cormack classification. But again, these are something which are usually done when you have enough leisure time and you have a lot of time in your hand to decide the intubation beforehand. Most of the times when you're doing it in an emergency, you have to be prepared for the worst in every scenario. So you have to be aware that you could need more help at any stage. So every intubation has to get its due respect. When we talk of intubation, this is what has been classically taught to us over the years, that there are three axes, and we need to align all the three axes, the line of vision, the laryngeal axis, and the pharyngeal axis. These are the three axes. And when you position the head in the sniffing position, which is putting your head out trying to sniff a rose or a flower, that is what you want to do to align those three. People have debated that, and there have been MRI studies done to see what exactly is happening with the three axes. And now what we know, it's more than the three straight lines, it's actually two curves. There's one curve which is bent posteriorly, which is the primary curve, and then there's a secondary curve which sort of meets at the laryngeal vestibule. And our idea of aligning is to actually align the laryngeal and the secondary curve and to press the primary curve. So primary curve is the curve which is formed by the tongue, and you're trying to press the primary curve. You can see it on the picture on my left, that you're trying to push up the lung so that your line of vision comes in direct line with the vestibular or the laryngeal inlet. So the ideas have changed, but what you do practically more or less remains the same. You still have to push the tongue up, you still have to get the vocal cords in view, and you still have to push the endotracheal tube in. So what is important is you have to assess the 3 points of difficulties that you would probably face if you are doing a difficult intubation. So when you're putting a laryngoscope, you are looking at the anterior column because you are going to move things forward. Then there's this middle column which is the airway passage, and the posterior column which is the neck. And you have to assess on these 3 different points to make sure that you are able to intubate the child or manipulate all these 3 parts beforehand. So you can never be too careful with airways. The day you let your guards down, it will bite you back. So you have to be always ready for a difficult airway right from the beginning, which means you need to have all your alternative plans ready, which includes having adjuncts for difficult airways, be it a laryngeal mask airway, intubating stylet, the light one, which is a lighted stylet, a bronchoscope, or the video laryngoscopes, which are now easily available across most of the places. So people have studied the effect of use of a video scope versus a normal scope, and in this particular study, it did not show any real advantage of using a video laryngoscope. But we all know when you have a difficult airway, it is a very good adjunct to have in hand because it does help the visualization of the cords, especially the very anteriorly placed cords. There was this very famous study recently published about the use of stylet. So stylet is a stiffening sort of a stick that you put inside the endotracheal tube. To make it stiff, you can give it a slight hockey stick bent at the tip, and that facilitates it passing through the laryngeal inlet. So the success, the chances of a first pass success using a stylet versus not using a stylet was studied in almost 1,000 patients, and it showed a significant chances of first successful intubation when you use a stylet. So I know many units use stylet regularly. Some use it only when you're not able to do a first pass, but this particular study showed that the use of stylet really facilitates your intubation, and it facilitates on just about every parameter for the sick children. So intubation needs planning, and it needs a set of drugs that you need to do serially with the idea what we call as a rapid sequence intubation. You assume that every child has a full stomach. You treat that every child is going to need a tube or airway secured quickly, and that is why you use a rapid sequence intubation, where we all use a modified sequence intubation rather than a rapid sequence intubation, which includes pre-oxygenation preparation with medications, which include sedatives and muscle relaxants. So it is important to understand that almost all children who get intubated should get intubated with a modified sequence intubation, which would include the use of sedative agents and muscle relaxants. What sedative agent, what muscle relaxant you might use would differ from case to case, but there are enough options, like you could use ketamine, propofol. Etomidate is a very safe drug when you have hemodynamic instability, but not a good drug when you are suspecting sepsis. Similarly, muscle relaxants, you can use succinylcholine, you can use rocuronium, vecuronium, atracurium. There are so many EMs that you can use for muscle relaxant. So, but the idea is no child should get intubated cold, which is without medication. So every child, it facilitates a good first pass and intubation, and is actually much safer and better for the child. But like any intubation, you should have your plans B, C, D, E all ready when you start your intubation. Your alternate plans do not need to get activated after you have failed first. So it needs to be ready there. You may, and you're most likely not to need most of them. So if direct laryngoscopy doesn't help, you go on for video laryngoscopy. If that doesn't help, you can go for a supraglottic airway to maintain airways while you consider fiber optic intubation. Or if that too fails, then you have to be ready for a emergency surgical airway. So these are the default strategies where your rapid sequence intubation fails, which is a can't intubate, can't ventilate scenario. Okay. So there are many algorithms. Most of these algorithms are anesthesia based, where they tell you various things that you would normally do stepwise, and if things don't work out, you stop the sedation and let the child wake up. That unfortunately is many times not an option for us. You really have to get the airway in, whether it is an endotracheal tube or a tracheostomy tube or a mini cricothyrotomy tube, you have to get it in. But there are algorithms, and it is a good idea to have such an algorithm stuck in your walls of your ICU. So let's look at these 4 scenarios just to get an idea. So this is a 6-year-old child, asthmatic, has a severe exacerbation, comes in severe distress, is drowsy, hypotensive, heart rate is 180, respiratory rate is 40, he's wheezing, working hard, the blood pressure is 80/40, capillary fill is more than 4 seconds, and the lactate is 6. You decide to intubate the child. Now the 16-year-old, dengue shock, very agitated, anxious, typical adolescent dengue, heart rate is 190, respiratory rate is 30, he's breathing hard, poor perfusion, blood pressures are low, he's puffy, he's got generalized edema. You decide to intubate the child. 1-year-old who has had a fall from height, he comes seizing, seizures stop after you give him lorazepam, you have decorticate posturing, he's gasping for respiration, blood pressures are 90/50, reasonably maintained. You decide to intubate this child. And another one, a 3-year-old child, a newly diagnosed diabetic who comes in diabetic ketoacidosis, drowsy, severe respiratory distress, as in work of breathing, and a gas shows a pH of 6.9, carbon dioxide of 8, bicarb of 5, and glucose, which is on your glucose sticks, is beyond the recordable ones. And you can see the blood pressure is 90/60, saturating 100% with the non-rebreather mass. So you got 4 different scenarios. All 4 children need intubation, and none of them on your examination have a likelihood of a difficult airway, anatomically difficult airway. But all of these are physiologically difficult airway. They are all at high risk of dying when you intubate them. And that is what is important. The physiological state of these children make them a very high risk candidate when you give them sedatives or when you switch from a negative normal breathing to a positive pressure ventilation. So positive pressure ventilation has its significant effect on the hemodynamics, and I'm going to just highlight on the right side of the heart. So when you increase the intrathoracic pressure, the right-sided venous drainage or return to the heart reduces. So the venous blood which is coming back to the right heart is reduced. On the right ventricle, the output gets affected if there is not enough expansion of the lungs. So if the lungs are overexpanded or they are underexpanded or collapsed, in both these scenarios, you can see it on the graph, the pulmonary vascular resistance would increase. So if the inflation is too much or too less, the right ventricle will find it more difficult to pump out the blood. So you put the child on ventilator, you put the child on positive pressure, the venous return or the preload to the right heart is reduced, and the afterload is also reduced, afterload is increased, and that greatly hampers the cardiac output of the right ventricle. The same blood is going to go to the left ventricle and get ejected outside into the systemic circulation. So if the right heart output is affected, so would be the left one. So this is a huge change, moving from a negative pressure ventilation to a positive pressure ventilation when you intubate the child. And these effects are multiplied, exaggerated significantly when there is a situation of hypovolemia. And when I say hypovolemia, I mean intravascular hypovolemia. You could have a child who's in anasarca, is totally edematous, but his intravascular volume could be very low. So such children, where you switch from a negative pressure to a positive pressure, this change in hemodynamics can be very drastic and can be life-threatening for such children. So people have looked at various criteria of a physiologically difficult airway, and this is a study which is quoted often in many places. This is where they retrospectively reviewed their data, came up with these high-risk criteria of hypotension, clinical concerns of cardiac dysfunction, persistent hypoxemia in spite of supplemental oxygen or positive pressure ventilation, severe acidosis, post-return of spontaneous circulation, status asthmaticus, and they have validated it further in next set of patients and found that these high-risk criteria, physiological high-risk criteria hold true. And if you have even one high-risk criteria, your chances of having adverse events with ventilation are significant. So let's look at all these cases that we discussed. So 6-year-old, severe asthma. So there is a severe negative intrathoracic pressure. Now the right ventricle is used, or right heart is used to this huge negative intrathoracic pressure to draw blood to the heart. As soon as I'm going to intubate and change it to a positive pressure, this output is going to have a massive fall. So the concern is of the severe negative intrathoracic pressure which should change, and the bronchospasm which could get worsened. So what do we do? If possible, try and avoid intubation. Most of the times we would be able to get away with non-invasive ventilation, and most of these days very, very rarely would we need to intubate a child with asthma. And then obviously you do the rest, and when you intubate you use a drug like ketamine which also has a bronchodilator effect. The child with dengue who's anxious and in shock, he's intravascularly deplete. You want to build up the intravascular volume, probably start some inopressors beforehand before you intubate this child to have a better chance of survival. Similarly, a child who has a fall from height, the concern here is an intracerebral edema or raised intracranial pressure. So your choice of drugs, your method of intubation has to be gentle on the brain. So you use lignocaine, use deep sedation. So a comatose child, it is very important that we use all the drugs of rapid sequence intubation and lignocaine to blunt the effects of the RASE and ICP, because that intubation can be damaging to the child. And similarly, the 3-year-old with DKA, here the pH is 6.9 and the child is breathing his CO2 out to single digits. Once you ventilate, and if the CO2 moves from 8 to say 15, that is enough to cause hyperemia of the brain. So here when you ventilate, you have to match the CO2 which was there when the child is breathing spontaneously. So you actually need to hyperventilate by the time the rest of the medications get into work. So these are the situations where you would actually try and avoid intubation as much as possible, because you know these situations have a turnaround time and you just have to support the child. So the time is up. So physiologically you need to correct the situations or optimize intubation, the hemodynamics as much as possible before the intubation. The post-intubation care is another subject. It's a long list of things that you need to do, and I think we can skip that. But the standard of care on ventilation is now a low tidal volume ventilation, which is the normal tidal volume ventilation. There are targets for various pressures, the driving pressures, the plateau pressures, and these are well defined, and I'm sure you've heard many speakers and in the workshops in the last 2 days. Thank you so much for your attention.
Thank you for your nice presentation. He has given trace on the few things. One of the, when you want to go to intubate a child, first you have to assess the child. This is one of the important thing. And when you go to the intubate the child, adjuncts should be kept ready. And anticipation has to be done for the difficult intubations, and that has to be also kept ready along with you for the proper intubation. And due to short of time, he was not going to the details of the post-intubation care, and he has given the what assessment has to be done before intubation. Thank you for your nice presentation.
Thank you, sir.
Thank you, sir.